Hello guys, this is the second of the series in pain control after major knee surgeries, and we meant by major knee surgeries the ACL reconstruction and the the total knee replacement or total knee arthroplasty. So the adductor canal is containing what we call it the saphenous nerve, which is the terminal sensory branch of the femoral nerve. And in addition to the saphenous nerve, the canal is containing some more nerves like the nerve to vastus medialis and branches from the obturator nerve, medial retinacular nerve. So in 2010, Kirkpatrick described the technique of saphenous nerve block using the ultrasound and color Doppler technology. And he was claiming that since it is difficult to visualize the saphenous nerve, we are using the superficial femoral artery as a landmark, injecting around the superficial femoral artery, and he called his block as superficial femoral saphenous technique. Superficial femoral artery saphenous technique. According to him, it seemed that it is not necessary to visualize the saphenous nerve in order to do this block successfully. In 2011, Lund and colleagues were the first to apply the concept of performing adductor canal block for the purpose of analgesia after major knee surgeries. They introduced the first perineural catheter and established that 30 ml of local anesthetic would effectively fill the adductor canal. Later on, Henningsen et al. Tested the saphenous nerve injury with ultrasound-guided adductor canal block. They demonstrated that no patients suffered saphenous nerve injury, and over 80% of the patient has successful block. This study highlighted two important aspects of this technique, as we will describe the technique soon. It established the technique safety for the saphenous nerve itself, not for the other structures, and demonstrated that even under controlled conditions, it's not 100% effective. So the adductor canal is aponeurotic tubing extending from the apex of the femoral triangle and ending in the adductor hiatus in the popliteal fossa, bound medially by the sartorius muscle, laterally by the vastus medialis muscle, and posteriorly by the adductor longus. The sheath include within its components is the saphenous nerve and nerve to vastus medialis, in addition to the femoral artery and vein. Outside the sheath, there is subarterial plexus of nerves that include the branches of the obturator nerve, medial retinacular nerve, and medial femoral cutaneous nerve. The electronic presentation that is presented online showed high resolution ultrasound machines can visualize the saphenous nerve in the proximal part of the adductor canal as hyperechoic mass lateral to the superficial femoral artery. Classical teaching for the adductor canal performance is we describe it as the point of injection is the midpoint of the thigh, which is presented by the red arrows here, midway between the anterior superior iliac spine and the medial epicondyle. However, is it truly the start of the adductor canal at this point? This is the subject of another study defining the location of the adductor canal using ultrasound, published 2017, and it was a randomized controlled trial including 22 volunteers with asaphysical status 1, and it is, as we mentioned, prospective randomized controlled trial. In all volunteers, the midpoint of the thigh, which is red here, red arrow, was proximal to the beginning of the adductor canal, which is blue, suggesting that an injection performed at this level, which is the red point, is in fact a femoral triangle block. Hence, the second name of the adductor canal block, it is femoral triangle block. Whether we are injecting proximal in the canal or distal in the canal will be visualized by ultrasound. The comparison of the continuous proximal versus distal adductor canal block in total knee arthroplasty is the subject of this study that published in Regional Anesthesia and Acute Pain. And by proximal, we describe the left-sided picture where the probe is located proximal in location and the superficial femoral artery is medial in location in relation to the sartorius muscle. As we go more distally with the probe, the superficial femoral artery is moving from its location on the medial side of the muscle to more lateral position, which is presented here by the picture on the right side. The study demonstrates that continuous proximal adductor canal block offers non-inferior analgesia compared with the distal continuous adductor canal block after TKA.
Now this is the superficial femoral artery,
and here
on the medial
is
side of the
video
sartorius muscle
showing
under the sartorius collar. This is
anatomy
proximal in the adductor
and
canal
what we
block,
mean
and
by
maybe in the femoral triangle.
proximal
We are going
and distal
more laterally.
location
The artery is
of
going
the probe.
more laterally, and here is this is lateral, and the other side is medial. So now in this position is more lateral. The block is here is equivalent to the first one, but less motor paralysis.
We are going more distally with the probe. Now,
This is lateral, and the other side is medial. So now in this position is more lateral. The block is here is equivalent to the first one, but less motor paralysis. Now take it down,
showing the Doppler ultrasound,
this is the femoral
Doppler
artery.
color flow. It is
more
better
on the
and
medial
more
side,
safe to show
more
the
proximally.
color Doppler so we can
Remove the color Doppler.
visualize the artery, as we will see in this
If we
video.
are moving more distally, smooth from the medial to lateral, where it is now more lateral. This is the proximal 1/3 of the adductor canal. And the hyperechoic mass on the lateral side of the artery is the saphenous complex neurovascular bundle.
this is the proximal 1/3 of the adductor canal. And the hyperechoic mass on the lateral side of the artery is the saphenous complex neurovascular bundle.
Yeah. Start.
Now,
Now the needle is coming from lateral, medial,
and
approaching,
doing the block. We will see
penetrating the muscle,
moving
and now I feel
lateral
a
to
resistance.
the medial,
This is the fibrous
targeting
sheath
the
that
hyperechoic
covers
mass lateral
the adductor
to the
canal.
superficial
Now
femoral
few cc's.
artery.
This will block the subarterial plexus of nerves, including the branches of the obturator nerve. Yeah. Now I'm penetrating the resistance, now penetrated, and the hyperechoic mass, this is the saphenous nerve, inject after withdrawal. Withdraw first, inject, no blood, inject, inject,
The branches of the
yes,
obturator
inject,
nerve.
withdraw,
Now I'm penetrating the resistance, now penetrating,
inject.
and the hyperechoic
Now
mass, this is
the saphenous nerve is floating now.
after withdrawal.
Inject.
Withdraw first,
20 ml
no
total.
blood.
Give me 5 ml more because you give extra adductor canal. 5 ml, so we need a 20 ml within the adductor canal because the capacity of the adductor canal give 5 ml is around 20 to 30 ml.
Okay.
This is finished.
20 ml total. Give me 5 ml more because you give extra adductor canal. 5 ml, so we need a 20 ml within the adductor canal because the capacity of the adductor canal give 5 ml is around 20 to 30 ml. So now the use of the adductor canal block versus the femoral nerve block. We compare comparison in anterior cruciate ligament reconstruction. There are two landmark studies showing this comparison. The first one published in Saudi Journal of Anesthesia 2015 by Muhammad Said Al-Ahl, and the second study was published in Anesthesiology 2016 by Faraj Abdallah from Canada. Are randomized controlled trials comparing the femoral nerve block to the adductor canal block for ACL reconstruction. As we mentioned, both are randomized controlled trial. In both groups had superior quadriceps strength in the adductor canal group by straight leg raising or by maximal voluntary isometric contractions. However, pain control differed between the two trials. Abdullah study from Canada found that the adductor canal block resulted in non-inferior analgesia and opioid consumption compared to the femoral nerve block. So, however, Al-Ahl reported lower pain scores at 18 and 24 hours, as well as decreased morphine consumption in patients receiving femoral nerve block when compared with the adductor canal block. The discrepancy could be attributed to the nature of the graft, hamstring to patellar graft, and the volume of local anesthetic 20 to 15 ml difference, and mentioned by Dr. Faraj from Canada, when I met him in Abu Dhabi, he told me that actually his block was more proximal in location, and this more explanation for his results. He's the one guy on the right side of the logo, and I am on the left side of the logo. When we are using the adductor canal block in total knee arthroplasty and comparing it to the femoral nerve block, a meta-analysis that is published in scientific reports in 2017. 12 randomized controlled trials comparing the adductor canal with femoral nerve block after TKA. And the conclusion, adductor canal block provide pain relief and opioid consumption comparable to femoral nerve block and is associated with decreased risk of fall. However, in 2018, another study in medicine described that the same total knee arthroplasty, but considering another aspect of the analgesia, which is early rehabilitation when the patient is starting to move, and the description of a lateral knee pain. It is a randomized controlled trial, and similar knee analgesia, analgesic effect regarding the opioid consumption, the complication occurrence, the sleep interruption caused by the pain. In the adductor canal block group, better effectiveness of early rehabilitation in quadriceps strength and range of motion and of the knee and the hospital stay. The adductor canal block is better than the femoral nerve block. However, the adductor canal block group could not relieve lateral knee pain in early rehabilitation. When we are adding obturator nerve block to the adductor canal block, does it make a difference? This is a study that randomized controlled trial. He recruited 78 patients divided into 3 groups. The first group is having the femoral nerve block in addition to the obturator nerve block, femoral triangle block in addition to the obturator nerve block. So this is one group. The second group, the femoral triangle block, which is the adductor canal block alone, and the third group is the local infiltration analgesia as a control group. And the conclusion of this study, the addition of obturator nerve to the femoral triangle block, which is the adductor canal, significantly reduce opioid consumption and pain after TKA compared with single adductor canal block or local infiltration analgesia without impairment of ambulation. When we are comparing the local infiltration analgesia to the adductor canal block, a systematic review published 2019 in Journal of Arthroplasty, 6 randomized controlled trial, and a conclusion, periarticular injection or local infiltration analgesia significantly improve the post-operative pain and opioid consumption when compared to the adductor canal block, and additional high quality studies are required. To complicate the picture for adductor canal block, in Anesthesiology January 2019, a case report by Farage and Leon from Canada, a case of uneventful ultrasound-guided adductor canal block, post-operatively absent distal pulsation An arterial duplex scan demonstrated femoral artery dissection flap. Color Doppler demonstrated an absent arterial flow distal to the dissection. A puncture site with perivascular hematoma and intravascular thrombus. Emergent thrombectomy and arterial repair. The patient subsequently regained limb perfusion. I hope by the end